So one follower asked me about ADR. So let me introduce a new term to all my followers. ADR stands for Adenoma Detection Rate. ADR, Adenoma Detection Rate, is actually a concept that experts use to monitor the quality of a colonoscope. So the principle is like that. Number one, we assume that for patients older than 50 years old, roughly 25% or maybe more of them will have a colon tubular adenoma when we do a screening colonoscopy. Tubular adenoma is a kind of polyp in the stomach that if we don't take it out, they become cancer in about 10% of the proportion. So we take it very seriously. So the principle is that we assume that most people above 50, like me included, will have a tubular adenoma when we do a screening colonoscopy. Then, if a doctor can detect roughly 25% or more, this doctor must be doing a fairly decent, fairly good colonoscopy. But if this particular doctor perform a lot of screening colonoscopy and his adenoma detection rate is low, then a few possibility. Maybe the scope is not well done, maybe his skill is not good, maybe he was rushing, he doesn't do it slow enough, or maybe it's just by sheer luck that his patients are different from everybody else. So there are many possibilities, but most experts will think that if a particular doctor's ADR is low, then maybe this doctor is not doing the scope properly. So this is one of the KPI, Key Performance Index, one of the matrix, one of the performance indicator, one of the quality indicators that experts use to see whether the doctor is doing the job properly. But there are a few caveats that we have to understand. First, this ADR actually takes into account both adenoma and cancer. So some patients have a cancer, we see a cancer, this is also documented as part of the ADR implication. Okay, not just adenoma, but cancer also. And there's some type of polyp, we call it hyperplastic polyp. Hyperplastic polyp, they have a much lower risk to become cancer, and hyperplastic polyp is not included in the ADR calculation. The next point is we only use screening colonoscopy first time. So if a patient has colonoscopy done before, this is a second scope, then we don't calculate it. We don't calculate the ADR. Or if the patient has symptoms like blood in the stools, change in bowel habit, constipation, abdominal pain, we also exclude them from this ADR. So ADR include adenomatous polyp, cancer in the colon. It doesn't include hyperplastic polyp, and the population of patients that we calculate only include first-time scope above 50 years old for screening colonoscopy with no symptom. So in a big hospital like Singapore General Hospital, National University Hospital, many patients go there for screening colonoscopy, and the hospital administrator can then calculate the ADR of different doctors. They can get a mean, and they will say that, hey, how come some doctors consistently get a high ADR, and how come some doctors consistently get a low ADR? Maybe it's not that he got his patient different from the rest. Maybe he wasn't doing his scope properly. Based on that, we can give the particular doctor advice, counseling, retraining. Maybe you can even watch how we do it, give him some coaching so that he do the scope properly, so that his ADR can be up to the average. In private practice, in my practice, we don't calculate ADR for the simple reason that we don't do that many screening colonoscopy. I would say 1 year I do probably very, very few. I would say less than 5 or 10 out of hundreds that I do for other patients. And that's not because that I don't like to do, I would love to do. I think colonoscopy helps detect tubular adenoma, it helps save life. The main problem for private practice in Singapore is that we have a very unique system, very weird system, that when you do a screening colonoscopy, as I mentioned, first time, no symptoms, above 50, this practice is actually approved by the American Gastroenterology Association, American GI Endoscopy Association, Ministry of Health, CDC, NIH, US, Europe, all the authority above 50. This is a recognized practice. But yet, we cannot use MediShield Life or integrated shield plan to pay for the screening colonoscopy. Even MediSave, I think we can't use as well. So when we do a screening colonoscopy in Singapore, MediShield Life doesn't pay for private gastroenterologists. Integrated shield plan doesn't pay. So patient have to pay the full amount from their own pocket. The insurance doesn't pay for it. For that matter, when patients come in for screening colonoscopy, I will tell them, I'm sorry, we don't do, I'm happy to do for you, but I need to warn you that your insurance will not pay. MediShield Life doesn't pay. Your integrated shield plan doesn't pay, okay? So patient will self-pay. So as a result, a lot of them go back to restructured hospital because it's cheaper. And then even if they pay the full amount, even because it's subsidized, it's cheaper, so they can afford to pay. So for that reason, I do very few screening colonoscopy, and therefore I don't have an accurate ADR. I do so little that the range will be very high, will be very wide, okay? But yes, in a big hospital, I think they have the data, they internally audit, and they can use it to see which doctor are doing more properly, more detailed, more thorough, and which doctor maybe they're rushing, maybe they don't wash the colon properly. So going back in summary, adenoma detection rate, ADR, we use it to see how many adenoma a doctor perform in a screening colonoscopy in those above 50. Roughly, most experts assume 25%, but for those that have symptoms, for those that have scoped before, for those that are below 50, for those that are doing it not for screening, for diagnosis like they have symptoms, then we don't have an ADR. One important thing that we have to say is that 25% that I mentioned are figures derived from most studies done in Caucasian countries, Northern America or Europe. What is the local Singapore or Asia ADR? What is the acceptable ADR? Maybe we have more polyp, maybe we have less polyp. We actually need more studies done in Asia to find that. Can we just plug a figure from Hong Kong or from China? Maybe not, because we are multicultural, multiracial. Hong Kong and China and Taiwan, they're mainly Chinese. And obviously India, Bangladesh, they're mainly Indian descent. And Malaysia, Indonesia, they probably have more Malay descent. So Singapore, what is the ADR that we should aim for? I do not think we have an answer that are based on data. We need to have more studies locally, published studies, to determine what is the acceptable rate that you think hitting this rate that imply you're doing the scope properly. So ADR is one of the quality indicator for colonoscopy. I will elaborate on more KPI on scope in my future videos. Thank you for listening.